form the sounds. Intrinsic muscles are going to change the shape of the arytenoid cartilage, and then that is going to either open or close your glottis more or less, and that will create the sound. So it's controlling your true vocal cords. Extrinsic muscles are controlling the position of your larynx. So when you swallow and it rises, that's an extrinsic muscle action. There are a lot of muscles in there, a lot of names. If you're going to medical school or some other place, some other teacher will ask you to know all of that. I'm not going to. Swallowing is important to talk about respiratory-wise because sometimes you get food in your respiratory tract. People get, kids get it all the time. Older people aspirate food all the time. Their coordination is impaired. Children, it hasn't developed enough. And in older people, it's impaired because of other neurological changes that are occurring with aging and maybe disease processes. When the food is pushed back to your the back of your oral cavity, you get a spontaneous contraction of your pharyngeal constrictor muscles. Don't have to know the names, that was last semester, but you have to know that once the food gets back there, it's going to get swallowed. So hopefully your muscles are coordinated enough that your epiglottis closes before the food reaches that point. Otherwise, food will be going into your airways. And we'll see where it usually ends up on a later slide. So we've got a response for swallowing. It's not, the term here is called deglutition. Also in your book, it's probably on the later slide, but swallowing is a reflex response. Reflexes have to be coordinated. So once the food gets pushed by your tongue and your cheek into the back of your throat, it will trigger this deglutition response. Part of the response is close the epiglottis so that when the food gets down to the level of the larynx, it's closed and will not enter the lower respiratory system. Food at this point is just called a bolus. Later on, when it's mixed with other things in the stomach, it will be termed chyme. And then when it's past the epiglottis, it's going down into the esophagus, which is right behind, posterior to the trachea. We get into the trachea. We had half a cartilage on the front, that's your thyroid. Complete circle of cartilage down below, that's your cricoid. Bigger on the back, smaller on the front. Then we get to the trachea, and the trachea has half circles of cartilage. They're called C-shaped cartilage, open on the back. The back of the trachea shares surface area with the front of the epiglottis, of the esophagus. And so when the food passes down the esophagus, the trachea has to accommodate by shrinking. We've got muscles that will pull the C of the cartilage closer together to give more room for food to pass down the epiglottis. When you're breathing, your epiglottis is closed down. It's not open, wide, there's no space there. The two sides of the surface are closed against each other. When food passes, you have to expand to accommodate, and the trachea then will shrink to accommodate the food going paths. The diameter of the trachea that's held open by the C-shaped cartilage, about 2.5 centimeters in diameter. Lining, respiratory epithelium, so pseudostratified ciliated columnar with goblet cells. And then there'll be other glands in the lamina propria, along with other cells and tissues in that area. And the submucosa will also have glands in it. We're going to, let's see. So mucosa. Mucosa is what is closest to the air that's traveling through the trachea. It's going to be, they'll have an epithelium that's sitting on a basement membrane. Epithelium is your pseudostratified ciliated columnar with goblet cells. The membrane is going to have a lot of, well, below the membrane, which is about 24 to 40 micrometers in thickness, so it's a pretty thick basement membrane. Under it, there's going to be a lot of white blood cells hanging out to just make sure that any pathogen that's in the inhaled air, it attaches and tries to get through the epithelium, through the basement membrane. There's going to be immune cells right there that will stop it in its tracks. Below the basement membrane, you have a submucosa, more mucus secreting glands, and also some what's called serous demilunes. These, since you have a lot of mucousy secretions, you need some water to attach to that mucus so it's pliable enough that your cilia can feed it over the surface of the cells. Without the water there, the mucus is too tacky. It gets stuck in the airways and can't get out, and then you can get bacteria and things that are in the mucus not killed, so they can then just thrive in the mucus and you get an infection. The serous demilunes will be associated with the mucus secreting cell to give enough water to the mucus to keep it slippery enough to be moved by the cilia. The ducts of these glands will be simple cuboidal epithelium. The secretions, besides the sticky mucus, which is glycoproteins, and the serous, which is going to be enzymes and other fluid, that will make up the consistency of the mucus. So how many C-shaped rings? It varies. I've seen some books say as low as 14. Upper limit usually is around 20, but it will vary from person to person. It's going to be hyaline cartilage. If you remember when we were studying epithelia last semester and connective tissue, we showed you the tracheal cartilage and said that's hyaline cartilage. And then, oh, by the way, move over here and you see pseudostratified ciliated columnar with goblet cells. So hyaline cartilage is what forms the C-shaped ring, and then your epithelium will be on the luminal surface. There's a ligament that attaches to the backside of those C-shaped rings. So now let's put posterior here and anterior here. We've got a C-shaped ring going like that, and across the back there's going to be a ligament kind of arc over there. So it's called an annular, which means arc shape. And then there's going to be muscle. It's going to attach to is going to be smooth muscle, and it's under autonomic control. What is back here is your esophagus, which is closed down. Until food goes through the esophagus, this remains open, the smooth muscle remains relaxed. When food passes through the esophagus, then that lumen opens. It's going to extend in the direction of the trachea. So the tracheal smooth muscle will contract, and now your C-shaped ring is pulled together. This gives you the room for the esophagus, the food passing through the esophagus to get past the trachea. So the ligament is called your annular ligament, and then I got this backwards, so muscle is inside. And smooth muscle is inside, and that is just called your trachealis muscle, for the name of the structure it's in, trachea. The connective tissue on the outside, adventitia, just a generic term for connective tissue that's going to attach the structure to other structures. So posteriorly, it attaches it to the esophagus, and then laterally and anteriorly, anterior to the great vessels, laterally to lung structures. Thyroid cartilage, cricoid cartilage, the C-shaped cartilage anteriorly, and then the annular ligaments in between. They attach the C-shaped cartilages to each other, and also posteriorly to itself, to the C-shaped ring. So posteriorly, look at it, all you're going to see is a strip of ligament going down the back of the trachea. Anteriorly, you'll see the hyaline cartilage. You get to this point where the trachea divides, that's called the carina. From that branching point on, you have bronchi. The first part of the bronchus is outside the lung, so sometimes referred to as extrapulmonary. Doesn't mean you have more of them, it just means extra means outside, so outside the lung tissue. Small part of it does extend into the lungs, so that would be intrapulmonary. Entering with the airways, you're going to have blood vessels. Exiting at that same area, you're going to have veins and lymphatics. You're also going to have nerves entering and leaving the lungs. So you have an opening into the lungs that's going to be called a hilum. And if you look at the pictures coming up and use your imagination, if you turn the lung upwards and you have all these branches going up, that's your tree, and you have a trunk, and then down below that would be the roots. So this is also referred to as the root of the lung. If you look right, primary bronchus is bigger around. It also is a little bit more vertical than the left primary bronchus. Doesn't show up too well on the illustration, but in real life, when you're playing around with the trachea and the bronchi, you can actually see that the right bronchus is a little more straight up and down. The left makes a little sharper turn, and so not quite so straight up and down. So being bigger and more vertical, that's where food that is aspirated usually ends up. going to end up in the right primary bronchus, or even down here if it's small enough into the secondary bronchus. It's not going to make it into the superior secondary bronchus because that's a right angle turn. It's going to end up down in here. Primary, when it branches, is going to form a secondary bronchus. The secondary bronchus, you have one for each lobe of that lung. The secondary, when it branches, you're going to have a tertiary bronchus. The tertiary bronchus is going to individual segments of those lobes of the lung. And those are referred to as bronchopulmonary segments. And we'll see those on a later slide. The cross section through the trachea, it's not stained like the lab slides are stained. This is a different kind of coloring. It's coloring everything red. So you got cartilage here. This is your hyaline cartilage. C shape in the trachea. Right back here, that's the space that is spanning between the hyaline cartilage. You have the trachealis muscle on the inside, and then your connective tissue ligament on the outside, your annular ligament. When the food passes through the esophagus is going to dilate to accommodate that food. The trachealis muscle will contract and pull the C-shaped cartilages together, and sometimes even overlapping each other to allow for more room for the swallowed food. You got some gnarly looking lungs there. Looks like a smoker's lungs, all black all over. Normal lungs are nice and pink, not black like that. The right lung has 3 lobes, a superior, inferior, middle lobe. Left lung only has 2 lobes. Reason is on the left side, that's for most of us where our heart is located. So in the embryonic period, we started with 3 lobes, but 2 of them fused together in the left lung to give the space for the heart that's developing in that area. You can see that the left lung actually forms around the heart, and there's a little indentation on the left lung that's called the cardiac notch, and it's folding over the heart in that position. When you look medially at both lungs, you'll see a large indentation on this side. It's actually called the cardiac impression. We also have an indentation on that side. That's where the other side of the heart is. But most of the indentations on the left lung side. Also see a large indentation that looks like a candy cane again. And that's for the ascending aorta, aortic arch, and descending aorta. Smaller indentation there for the esophagus. You see over here superior vena cava indentation. The lungs actually take on the shape of the structures in the surrounding area. Even after death and you remove the lungs, there's still those impressions on the surface of the lungs. So all the branching of your vessels off the aortic arch, you can see the impressions there in the lungs. Look at the root of the lung, look at the hilum. What is going in? You're going to have your superior lobar bronchus, your middle lobar bronchus visible and then you're going to have a branching for the inferior lobar bronchus. The bronchi on the right tend to be a little more superior. The bronchus and the pulmonary arteries are going to travel together. Everywhere the airway branches, the artery is going to branch all the way out to your alveolus. So they're going to be following each other through the lungs to the level of the alveolus. Here you've got the pulmonary artery and the bronchus also associated right together. The veins, they take the shortest route back to the heart, so they're not going to be following the airways at all. They're just going to take a shortcut back to the hilum and then back to the heart. Right side, the pulmonary veins tend to be inferior. There's still, one of them is still inferior on the left side. The other one is a little bit more superior. So term extrapulmonary means outside the lung tissue. So extrapulmonary bronchus is what's outside here. And then what's inside the lung tissue, that will be intrapulmonary bronchi. They're primary bronchi first when they enter the lungs, but immediately, for the right for sure, immediately upon entering, it branches and forms the lobar bronchi or secondary bronchi. Those terms can be used interchangeably. So secondary bronchi, their destination is the individual lobes of the lung. There'll be 3 on the right and 2 on the left. So you have 2 lobes on the left, 2 fused in embryologic development, and so the airways were not necessary anymore. Fuse those together as well. The tertiary bronchi are the branching of the secondary. Those will go to individual segments of each lobe that are called bronchopulmonary segments. So these can also be referred to as segmental bronchi or a segmental bronchus. Those terms, tertiary and segmental, are interchangeable. Importance of these bronchopulmonary segments. If you're going to be a thoracic surgeon and you're going to be treating people with tuberculosis or maybe spontaneous little leaves that allow air to leak out into the thoracic space and lungs collapse, you might want to go in there and surgically remove the part of the lung that is causing the problem or has the bacteria in it. If you know your bronchopulmonary segments, you can remove the airway and the arteries and veins going to and from that segment and not damage any tissue around it. So you can surgically take out that individual bronchopulmonary segment. The rest of the lung is perfectly intact. Assuming, of course, that you closed up all the blood vessels and all the airways and everything, not just excise it, but you did the proper surgical technique. So on the right side where you have 3 lobes, you're going to have the 3 secondary bronchi that will then branch and form tertiary bronchi that will go to your bronchopulmonary segments. And there are 10 bronchopulmonary segments in the right lung. On the left side, you only have 2 lobes, so you might think, well, then I'm going to have 5 bronchopulmonary segments because it's going to be half of what's there, or maybe you think, well, maybe it's going to be 2/3 of what's there. But actually, you end up pretty close to the same number of bronchopulmonary segments. Usually around 8 or 9 are left, not 5 or 6 are left. But so the left has fused the lobes, but the bronchopulmonary segments are pretty much left intact. To keep a bronchus open, you don't have C-shaped cartilage anymore, but you have chunks of cartilage. They're called cartilage plates that will be in the wall of the airway, and enough of them that you have a pretty stable airway that's going to be hard to close down. The secondary and tertiary, they also have cartilage plates, but since the airways are getting smaller, so are these little plates of cartilage. So they're, with a decrease in size of the cartilage, there is an increased likelihood that those airways can get closed down. So when you have bronchitis and you have inflammation in the bronchi, smooth muscle constricts, tertiary and maybe some secondary, if it's bad enough, can close down. Probably not going to close down a primary bronchus, but if you close down tertiary, then everything from that point on is not going to receive air, and also no air can exit from the alveoli. What usually is more likely to close down with all the pathologies that happen in the lung are bronchioles, because they have no cartilage to keep them open. They have smooth muscle that will change their diameter, but all you need to do is introduce some histamine into that situation, and you're going to get smooth muscle contraction, and then those airways are going to close down. And also, the bronchioles are held open by a tethering effect of the rest of the lung around those airways. So they're attached to alveoli that are around them, and they're attached to other alveoli out to the surface of the lung. And then the visceral pleura is attached to the parietal pleura by this watery attachment of hydrostatic forces in the pleural cavity. And then the parietal is attached to the chest wall. So the chest wall will want to stay out, and muscles will help to pull it out. And it can only go in to a certain extent because of the ribs coming so close together and the muscles coming so close together that normally you've got a nice tether, a nice ability to keep those bronchioles open via all that attachment to this rigid, semi-rigid chest wall. But if you start losing alveoli walls, if they start to break down because of infections or smoking or some other asbestos or something that got into your lung, when you start to lose the walls of your alveoli, you get less and less tethering of those bronchioles. Let you just attempt to blow out a birthday candle and forcefully expel a little extra air, bronchioles snap shut. And sometimes you don't even have to try and exhale. Just normal breathing in, they're open, and normal exhalation, they shut down. And then you trap air in your alveoli that are still open. We'll talk some more about pathology shortly. So here are your bronchopulmonary segments. They've gone into the tertiary bronchi, individual tertiary bronchi, and then injected the silicon, different colored silicon, into the tertiary, and then allowed that to go out under pressure into the alveoli. So they've color-coded each of the bronchopulmonary segments here. And there should be 10 here and 8 to 9 over there on the left. So out here, extrapulmonary primary bronchus, intrapulmonary primary bronchus. First branch, you now have secondary bronchi. This is left lungs, you got two branches. One will go to the superior, one will go to the inferior lobe of the lung. The next branching, you don't see any further branching here, but down here we got some branching of the secondary. This is forming tertiary bronchi. Those will go to bronchopulmonary segments. You get down to this level, you have, this is still the branching of the tertiary. Here we've left the tertiary where you have cartilage to help keep it open, and you've entered a channel that just has smooth muscle. When it only has smooth muscle, you've entered the bronchioles. Bronchioles will continue to branch about 16 times more. So there's a huge number of huge increase in the number of those airways. When you finally see a little bubble on a bronchus, you've reached a point where you can gas exchange. That little bubble there that you can see, those little bubbles are alveoli. When the bronchus has one alveoli on it, it's called a respiratory bronchiole. Right above that, where there are no alveoli, it's a terminal bronchiole. So if you final branch with no alveoli, it's a terminal bronchiole. Beyond that, if it has an alveolus, it's a respiratory bronchiole. The alveoli will become more and more numerous and the wall space will become less of the surface area. You'll have a channel that has majority of alveoli, but still some smooth muscle in the wall. That will call it alveolar duct. It's primarily alveoli, but it's still a channel. And then you'll enter an area that is all alveoli. And it'll be cells making up the squamous cells or cuboidal cells making up the whole surface area after the alveolar duct. And then that's called an alveolar sac. So out here where you have these little grape-like clusters, those are alveolar sacs. So I talked to you about the tethering. Diameter of the bronchioles really, well, they can be kind of big, up to about 0.5 millimeter. But then you look at what is a 0.5 millimeter, it's not that big. And they will get smaller and smaller as they go to the terminal bronchioles that will then end in the beginning respiratory bronchioles, then alveolar ducts, and finally the alveolar sacs. Bronchodilation is under sympathetic nervous system activity. Bronchoconstriction, parasympathetic nervous activity. So when you're in rest and repose, you've got more bronchoconstriction. When fight or flight, you've got more bronchodilation. So more air in to support the muscle activity of a sympathetic response, less because you're pretty much just sitting around or digesting. So this note says 14, I think your book, I think Sherwood says 16 branches, but this is from Martini. There's going to be a little bit of variation, but 14 to 16 times after the tertiary bronchus, you're going to have that many more divisions. The small terminal bronchioles, you're not going to have pseudostratified ciliated columnar there. The diameter is too small. The cells are going to be closer to a cuboidal shape. They are subject to closing down, especially if water attracts other water. So hydrostatic surface tension down there is going to be high. So the cells, they have cells called Clara cells in the terminal bronchioles that will secrete kind of a fatty substance into the water. It has a detergent-like effect. It has a surfactant-like effect. It gets in between water molecules. It's hydrophilic enough it can associate with water, but it's also hydrophobic enough that it pushes water molecules apart. So it's lipoprotein. Protein can associate with water, but the lipid's going to repel the water. Keeps the water molecules far enough apart to keep the airways open, even during forced expiration. When you exhale as hard as you can, you're creating pressure on those small airways. If the water molecules can get close enough together to attract each other, the airway's going to snap shut. So with this lipoprotein in there, you keep the water molecules far enough apart during forced expiration that the airways don't collapse. And when the pressure is taken off, they open back up to their maximum diameter. So Clara cells, they're not surfactant secreting, but they secrete a substance that is acting similar to surfactant to reduce the surface tension of the water in the airways. The respiratory bronchioles, you're going to see Clara cells there as well. But the more and more alveoli that appear, the more of the true surfactant secreting cells will be present, and the less need for Clara cells will exist. When you get to alveolar ducts, you're not going to see Clara cells there because you have enough alveoli and their surfactant secreting cells. You don't need the lipoprotein from the Clara cells. Surfactant creating cells, secreting cells, they're called type 2 pneumocytes or type 2 cells of the lungs. The type 1 cell is the most numerous, probably 95% of the alveolus is made up of the type 1 pneumocytes, which are just simple squamous epithelial cells. Very thin, so gas diffusion can occur very quickly. You're going to have a simple squamous cell in the alveolus and a simple squamous epithelial cell in the blood vessel. They're going to share a basement membrane, so that decreases the diffusion distance. You're going to get diffusion happening through surfactant, through the alveolar simple squamous cell, through the basement membrane, and then into your blood vessel. So here's a picture of what happens at the end of a terminal bronchiole here. You've got alveoli apparent here, so this is a respiratory bronchiole. These little rubber band looking things, those are capillaries that are on the surface of the alveolus. You're going to have the pulmonary artery following every division of the airway out to the level where the alveoli are present. Then they'll have capillaries that will branch off the artery and go around every single alveolus, just huge surface area of blood vessels on the surface area of the alveolus that's underneath. So gas will come into these alveoli and then diffuse across the barrier, enter the blood, and then go back out via the pulmonary veins back to the heart. So oxygenation occurs, the hemoglobin, iron is now getting oxidized, the blood turns red. When it's not oxygenated, then there's a bluer color to that hemoglobin molecule. How many alveoli in a lung? 150 million. I'd like to have $1 for every alveolus in my lung, or at least one for every 10. That would be good. Or every 15. I could live with that. But anyway, got a huge number of alveoli there. And each alveolus will have a whole capillary network around it. So very efficient for gas exchange. Pick up oxygen and release CO2. The tissue is very elastic. So when your chest wall expands, it stretches very easily. You're sitting here, you're breathing 500 mLs of air in and out of your lungs with every cycle of your breath. You don't feel any tension. The lungs stretch very easily, and then when you take away the muscle force, they will collapse in and the air will come out. So you've got a very compliant tissue, meaning it doesn't take a lot of force to get that to stretch. When it stretches, it decreases the pressure, the volume's going up, and air will come in. When you turn off the respiratory muscles, then that elastic tissue will recoil, will help to pull in the chest wall. So there's no need to work for quiet expiration. All you have to do is turn off inspiration. So type 1 pneumocytes, squamous cells, thin, short diffusion distance. Type 2 pneumocytes are cuboidal cells. They are secreting the surfactant. The surfactant is quite a combination of different secretions. We'll see that on a later slide. So they're going to need Golgi, they're going to need rough endoplasmic reticulum, they're going to need some smooth endoplasmic reticulum, they're going to need a lot of organelles. You're not going to find all of that in a simple squamous cell. You're going to find enough of that in a cuboidal size cell to do what is needed. So type 1 and 2 pneumocytes, and then this is going to be about 95%. It's going to be all these squamous cells, and the rest will be vacuum secreting cells. You're also going to see alveolar macrophages. They're named for their place of action. If your respiratory mucus and ciliated cells don't prevent particles from getting down to the alveoli, then it's the job of the alveolar macrophage to phagocytose those and antigen present if necessary. So their job is to phagocytose particulate matter. If you're a smoker, if you work in an area where there's a lot of automobile exhaust or other particulate matter that is in high enough concentration, or you're inhaling very forcefully, you're going to get some of that particulate matter past your airways cleaning mechanism. So you need the alveolar macrophages there. If you're in lab, you saw coal dust lungs. The black there is not the coal dust. It's the coal dust that's been phagocytosed by the macrophages and they died in the process. And so it's macrophage with coal dust in it that we see in those lungs. So Thursday we'll finish